We're going to jump straight in and look at drugs that commonly come up in finals, but when are they contraindicated? What conditions should you not give these drugs in? And I've made a list here of the different disease processes that you shouldn't give certain drugs in. So with asthma, for example, drugs such as beta blockers, and adenosine should not be given. So adenosine used to terminate specific supraventricular tachycardias. Beta blockers used very commonly, and you shouldn't give them. They're relative contraindications because obviously senior people might choose to give these drugs to people, but in general these are things that you should realise carry risks, and this is the whole point of knowing these, is that you know these carry risk, and the risk of these is bronchospasm and asthma. In hypertension, so anything that is like a COX-2 inhibitor, like celecoxib, for example, or non-steroidal anti-inflammatory drugs, they can essentially increase hypertension via sodium retention. So non-steroidal drugs and COX-2 inhibitors are avoided generally in hypertension. With Parkinson's disease, you should not give neuroleptic drugs. Now, what are neuroleptics? Neuroleptics are also known as antipsychotic, or they're major tranquilizers. They're a class of medication primarily used to manage psychosis in conditions such as schizophrenia and bipolar disorder. They include clozapine, olanzapine, quetiapine, very common, risperidone, aripiprazole, etc., etc. So avoid neuroleptic drugs in Parkinson's, and the reason you do that is because it can worsen their symptoms, so it can worsen Parkinsonian symptoms. Worsens Parkinson's disease. In respiratory failure, this is a relative contraindication because they're used all the time in people with respiratory failure, but in general you should be aware that opiates are used with caution because they reduce your respiratory rate, they give you respiratory depression. Next thing is AV block. So what drugs should we avoid in atrioventricular block? We should avoid digoxin. We should also avoid beta blockers. We should avoid the calcium channel blocker diltiazem, and potentially verapamil as well. They can essentially cause complete heart block in certain cases. But I mean, all of these are quite relative contraindications, because you'll find that a consultant cardiologist might use this, but once again, you just need to know that these things can exacerbate an AV block. Now, moving then on to epilepsy, what should not be given with epilepsy? So we would avoid things like tricyclic antidepressants, antimalarial drugs, and antipsychotics. And the reason is these reduce seizure threshold. So they reduce seizure threshold. You can read that. Seizure threshold. The penultimate one is liver disease, and I'm talking about chronic liver disease, and an example of a drug you might want to avoid in liver disease is warfarin. So in people with chronic liver disease, they might have reduced clotting factors. They might be coagulopathic with liver disease because your liver produces most of your clotting factors, and is the home of sort of all of your intrinsic pathways, etc., like that. So this can cause bleeding. So whenever you're essentially anticoagulant with warfarin, but you're also coagulopathic with liver disease, potentially it can make warfarin work more, so you get the more effective warfarin, because don't forget warfarin inhibits factor 2, 7, 9 and 10, your vitamin K dependent factors. So essentially they all come from the liver. If they are less, then warfarin's going to work more because it has less to inhibit, and so you are more likely to bleed with warfarin and liver disease. Now, with renal artery disease, you can sort of maybe guess some of the things we're not going to be using, and essentially they are ACE inhibitors and angiotensin receptor blockers. That's actually angiotensin 2 receptor blockers, so angiotensin receptor 2 blockers, and they essentially reduce renal blood flow. If you have stenosis of your renal arteries, you're reducing renal blood flow, and you can cause AKI, leading to renal failure. And that's a pretty good list for drugs that are contraindicated. So in this list, we're going to be looking at what are called pharmacodynamic problems, and they are interactions that certain drugs have with other certain drugs that cause an interaction or physiological problem within the body. And that's what the pharmacodynamic means. These are the nasty. So beta-2 agonists are things like salbutamol, they're the inhalers, they're the nebulizers, and they should not be given with beta blockers. So I'll put a plus. Beta blockers, because they give bronchospasm. And the reason you shouldn't give both of them together is because you won't get the effect of the beta-2 agonist, and the beta blocker will usually prevail and cause bronchospasm. That's the technical sort of reason why. The next thing is beta blockers themselves. You shouldn't go with those with either verapamil or diltiazem, because they give either asystole or bradycardia. The next one would be ACE inhibitors, and ACE inhibitors shouldn't be given with loop diuretics. And that is because these drugs together will cause hypotension. Now, digoxin is a drug that, if in doubt, will usually cause nastiness with other things. Digoxin should not be given with amiodarone, because it can cause heart block. That's right, HB, that means heart block. Should not be given with verapamil, because it can cause heart block. And it should not be given with diuretics, because it can lead to hypokalemia, which can lead to toxicity of digoxin, so they can become digitoxic, and you would need to use digibind. Once again, these things can be used, I'm sure, in combination with each other, and indeed ACE inhibitors and loop diuretics, for example, are used with each other, and sometimes beta blockers plus diltiazem, verapamil, or beta-2 agonists can be given beta blockers under specialist guidance, in inverted commas. They do happen, but these are the things that you need to know for your exam. These are the interactions, these are the very common pharmacodynamic drug interactions that they are looking for to ask you about in your final exams. So the next thing we're going to talk about is pharmacokinetic nasties, or pharmacokinetic drug interactions, and we're going to be looking at the two different drugs that shouldn't go together because they cause intrinsic problems with pharmacological systems within your body, absorption of things, failure of physiological mechanisms. So to start, we look at warfarin. So warfarin and aspirin, or any of the P450 enzyme system inhibitors, because they're inhibiting an enzyme system that breaks down warfarin, essentially will cause an increased bleeding time. So they become too anticoagulated. The oral contraceptive pill plus antibiotics. Or anti-epileptics can mean the OCP fails, and that is not good for contraception. Theophylline and any of the P450 inhibitors. Can cause arrhythmias. Iron and calcium, such as in antacids, can cause reduced iron absorption in the enteral tract. Digoxin and quinidine which is used as an antiarrhythmic, can cause bradycardias. Lithium plus thiazides, so those are diuretics such as bendroflumethiazide, or non-steroidal anti-inflammatory drugs, can cause essentially failure of excretion of lithium. Lithium is a sodium-like compound, so if you are removing sodium from your renal tubules where it's excreted in the urine, you bring it back into the body, you do the same for lithium. It's essentially treated very similarly to sodium in the body, and therefore you can get high levels of lithium, which leads to seizures and ataxia. Azathioprine, which is it's an immune modulator, and with allopurinol, which is a xanthine oxidase inhibitor, can actually lead to bone marrow suppression. The last thing is to just make mention of the hepatic cytochrome P450 enzyme system, which I'm sure you remember from early on in medical school. It's important in oxidation reactions in the body, and essentially activity can be induced or it can be inhibited. If the enzyme activity is induced, this means there's an increase in P450 enzyme levels, which means there will be less drug if the drug is metabolized to its inactive form by P450. If the enzyme system is inhibited, it means there will be less P450 in the body, which means there will be more drug available if that drug relies on P450 to be broken down to inactive. And there are certain drugs, as we made mention of with interactions, such as warfarin, for example, which are affected by drugs that are inhibitors or inducers. So if we look at the mnemonics that I've put in front of us, we have got MC feed cake, as our inhibitors, which would reduce the level of P450 in the body, and we have inducers, which would increase the level of P450 in the body. So, and that's with the mnemonic gap price. Now, if we look at the MC feed cakes, on this side, we have metronidazole, we have ciprofloxacin, we have fluconazole, erythromycin, we have ethanol, alcohol, as in the one you drink, dextroproxyphene, don't worry about that, cimetidine, amiodarone, ketoconazole, antifungal, and etomidate, which is an induction agent in anesthetics. For the inducers, you would have griseofluvin, kind of alcohol, as in the one you drink, phenytoin, primidone, rifampicin, inhalational anesthetic agents, anesthetic gases, to worry about those either, carbamazepine, and ethanol. So you've also got ethanol, and you've got chronic alcohol. So those are like being a chronic alcoholic can cause it. So even if you remember the mnemonics, and remember a couple of these are drugs which influence the hepatic P450 enzyme system.